I'm Director of Patient Education and Advocacy at Kidney Cancer Canada, and I welcome you this evening. I am very excited to introduce Dr. Matthew Young of the Dr. H. Bliss Murphy Cancer Center in St. John's, Newfoundland. And I'm sure I said that wrong, Newfoundland, apologies. Dr. Young, I'm so glad to welcome you this evening, and we are so looking forward to updates in RCC, oncology. I think we hear around the grapevine that there's lots of new things happening and maybe some changes to old therapies. I know there's some clinical trials going that are quite exciting, so I'm looking forward to your updates. I just would like to share that Dr. Young received his medical degrees from Memorial Hospital in Newfoundland and his degree in oncology at McGill University in Montreal. He completed a 2-year clinical research fellowship and clinical trials and GU cancers at St. Bart's Cancer Center in London, England, with Dr. Tom Poles. Dr. Young is an investigator on several phase 2 and phase 3 clinical trials, and his interests are in drug development and for kidney and bladder cancers and biomarkers. He's a successfully published international author for kidney cancer and a clinical assistant professor in oncology. I kind of stumbled through that, Matthew, but Dr. Young, I'm so glad that you joined us, and I'm going to let you take it away. I'm just going to quickly remind our French-speaking attendees that at the bottom of the screen, there's a button that says interpretation, and this is simultaneously translated for our French-speaking attendees, and we hope that you'll take advantage. And just also a quick update that this will be available on our website once edited in both English and French, and will also be updated on our YouTube channel. Thank you so much for joining, and I'll see you after the presentation.
I was thanking Christine for the very kind introduction and invitation to join you all tonight. I'm very delighted to be here as part of the programming from Kidney Cancer Canada. As Christine said, I'm a medical oncologist. I'm currently practicing in Newfoundland in this building in the bottom left here. I did my oncology training at the McGill University Health Center, which are these brightly colored buildings in the middle, and then spent just over 2 years at St. Bart's Hospital, where I focused mostly on clinical trials with kidney cancer. So some of the most latest trials I was part of during my time there. These are my disclosures. So renal cell carcinoma is the most common type of kidney cancer. It accounts for 90% of all renal malignancies. It's the 14th most frequently diagnosed cancer. In 2020, there were over 400,000 cases worldwide, and we're seeing an increase in the incidence or the number of cases per year of kidney cancer. And while that sounds alarming, that's often now due to incidental detection because of increased use of CT scanners. So once upon a time, before the widespread use of CT scanning, patients would often present quite late in the disease course. But now we're finding these sometimes on accident before symptoms arise, which is improving outcomes. We're also improving our treatments for kidney cancer. So despite an increase in the number of cases per year, the mortality from kidney cancer is decreasing. I thought I would touch on a few things that might be coming in the pipeline in the diagnosis of kidney cancer. So there are new imaging modalities that have fairly good evidence. And one of those is this fancy PET scan with a radioisotope called a girentuximab. I'm probably not pronouncing that perfectly, but this is a new type of PET scan that is specific to clear cell renal cell carcinoma. Clear cell renal cell carcinoma is the most common type of renal cell carcinoma. It's about 80%. And the other 20% is what we typically call variant histology, or essentially different types of renal cell carcinoma that don't have the clear cell features under the microscope at diagnosis. There was a fairly large trial that looked at how well this type of PET scan could be used to make a diagnosis of kidney cancer without the need of biopsy. And what they did is patients had the PET scan, and then it was compared to their pathology with biopsy or nephrectomy. And it was shown to be very sensitive and specific. This raises some questions on whether or not this type of PET scan might be able to replace biopsies when that's needed for clinical decision making, whether or not this could be used in patients with advanced kidney cancer or metastatic disease, and if we could be using this to monitor response more accurately than what we're currently doing with CT scanners. So while this does not have widespread use or uptake across Canada, I think it's perhaps one of the more exciting imaging modalities we have in the diagnosis. So when we think about kidney cancer, it's often broken down into localized renal cell carcinomas or advanced renal cell carcinomas. And the distinguishing feature is usually whether or not we can use surgery to remove all of the cancer. There are two ways of doing that. I'm not a surgeon, but there's decisions making on whether or not something can be done called a partial nephrectomy, where part of the kidney is removed, which includes the tumor, or a radical nephrectomy, where the entire kidney is removed. It's been difficult to determine if one is superior to the other. And part of that might be because it's very difficult to accrue patients or convince patients to partake in a clinical trial where we're saying, well, you can either have part of your kidney removed or a complete kidney removed. And we won't know until the day of the surgery when you're randomized to having one or the other done. So there have been attempts, despite that not being a very good sales pitch. And there was one trial that closed prematurely due to poor recruitment. There did seem to be some benefit for a partial nephrectomy where possible. And that's not actually directly related to the kidney function, but actually more downstream effects of having reduced kidney function, including cardiovascular protection. So where possible, partial nephrectomy is usually preferred. There's also been reported quality of life improvements from patients who have had partial nephrectomies when compared to the complete nephrectomy. The technique of how the surgery is done is much more technical, and it really comes down to surgeon expertise and what equipment is available at the site of the surgery. So you can do something called a robot-assisted nephrectomy or partial nephrectomy, or a laparoscopic procedure where cameras or portholes are used. Open surgeries were commonplace and are slowly phasing out where possible, but sometimes is required. One of the areas that's being explored quite actively is whether or not we can do non-surgical approaches for kidney cancers. This is because not all kidney cancers are aggressive. They might not require the surgery, which has implications with kidney function, cardiovascular health, and quality of life. And some kidney cancers may be able to be managed without undergoing such a serious surgery. There's different ways we can do this. These are often done by, again, non-medical oncologists like myself. They're typically done by radiologists in conjunction with urologists. So there's procedures called radiofrequency ablation, which is like using heat to burn or kill the cancer cells. Something called cryoablation, which is a similar but technically opposite procedure where you're freezing to destroy cancer cells. There's also radiotherapy. So traditionally, or historically, I should say, radiotherapy was difficult to employ for kidney cancers. But we now have better types of radiotherapy that are more focused. We can give higher doses of radiation, which can include larger areas. So there's something called stereotactic ablative body radiotherapy, or SBRT, which is becoming quite a common strategy for localized kidney cancers, particularly in patients where a surgery may be unsafe. And active surveillance is sometimes very appropriate. So this is not just waiting until something goes wrong. Active surveillance takes advantage of the fact that some kidney tumors have a very low growth rate, and their likelihood of spreading to other parts of their body or becoming advanced or metastatic disease, it can be as low as 1 to 2% per year. And so because of that, sometimes it's more appropriate to watch until the kidney is either changing in how quickly it's growing, or there's otherwise concern. And this uses predefined time points in which scans are performed to make decisions at each time. I just want to briefly mention the Fast Track 2 study, which was a clinical trial looking at the SBRT. So that's the high dose, very focused type of radiotherapy that I mentioned. And so this study was an Australian study. It looked at patients who had what was deemed to be inoperable kidney cancer, but was biopsy proven. So these weren't suspicious masses. These were definite cancers. They were patients who had a single tumor, which is important. And it was decided at a multidisciplinary meeting, sometimes we call these tumor boards, that a treatment was needed. And so that usually suggests that there's something about the tumor mass that makes the physician or the patient worried that leaving it and watching this is not appropriate. This may have been inoperable because of size, locations, or patient health factors that influenced the decision to say that surgery wasn't appropriate. They included fairly large tumors, so up to 10 centimeters in size. And patients received 1 to 3 doses of radiation, depending on the size, so higher doses for larger tumors. And 70 patients in total were enrolled. The average age of the study was 77 years, which tells you that this is technically an older population than maybe some of the other surgical trials where we typically see the median age or the average age to be in the 60s. What's really impressive with this study is that the local control rate at 12 months after radiotherapy was 100%. So all patients had good control of their cancer and there were no cancer-related deaths. So this is a trial of 70 patients only. We have to be cautious when we're using small numbers to make sweeping statements, but I think this is certainly encouraging that SBRT may be a very suitable alternative to surgery, particularly in cases where surgery is not appropriate. And I know this is being actively pursued in Canada at multiple centers, including the one here in Newfoundland. And it's a really good strategy for those patients who might not wish to have a surgery or where surgery isn't a possibility. So once we have a surgery, how do we prevent the cancer recurrence? And cancer recurrence is a hard thing to wrap our heads around sometimes. And I always say with my patients, when they come to me for the discussion of having treatment after surgery is, what's the point of having treatment if the surgeon tells me they got it all? And what I have to explain is that the trouble is not whether or not the surgeon felt confident that they got it all. Oftentimes they do. It's that there is a possibility that teeny tiny cancer cells that can't be seen on any of these fancy scans I've mentioned could be hiding away somewhere and could have escaped the kidney. And the only thing that tells us if that happened is if subsequently down the road, patients have a cancer recurrence. And the reason we want to care so much about preventing this is because often when cancer recurs, it's deemed to be incurable. There are exceptions to that. Sometimes we are able to do repeat surgery or other techniques like radiotherapy to kind of reintroduce a remission. But this is our window of opportunity after surgery to talk about ways that we can reduce a recurrence. So I want to talk about pembrolizumab, which is a type of immunotherapy. It's something called an immune checkpoint inhibitor. And in case this is the first time people are hearing about immunotherapy, I like to think of immunotherapies as drugs that we give to try for the immune system to do its normal functioning job, which is recognize that cancer cells are misbehaving. There are cells that are not behaving like normal, typically healthy cells. They should not be there. But cancer is unfortunately very clever. It puts brakes on the immune system. It basically says, don't worry about me. And immunotherapy tries to undo that brake. And so it allows the immune system to do its job. And so there's been a lot of excitement with immunotherapy in kidney cancer. It was initially proven to be very successful in metastatic or advanced disease, which I'll cover. But there's been active exploration, a lot of data for whether or not immunotherapy could work after surgery to prevent recurrence. And the first study that showed a significant benefit in preventing cancer recurrences and making patients live longer with high-risk kidney cancer was this Keynote 564. And you can see here, it was published in August of 2021. And that initial readout of the trial showed that it significantly improved something called disease-free survival, which is a time between surgery and first episode of recurrence. And for some patients, it may have meant a cure. And it was updated just under 3 years later with a significant improvement in overall survival. So this has been practice-changing internationally. So what this trial was, it was a phase 3. So it was a big trial with lots of patients. And they gave adjuvant pembrolizumab. So adjuvant is the word we use for treatments given after surgery to reduce the risk of recurrence for 1 year. And it used a term of intermediate high or high risk renal cell carcinoma. And this was a novel, meaning a new risk strategy. We often talk about kidney cancer as being favorable, intermediate, or high risk in advanced cases. But after surgery, we had been using fairly historic ways of determining whether or not patients had a high risk of cancer recurring. And this study took advantage of using this new way. And so it looked at very pathologic or technical terms on the pathology report. And it includes more than just the size of the tumor. It really includes, is the tumor invading important structures like veins, blood vessels, or lymphatic system, or lymph nodes, or whether or not the cancer had already spread to other parts of the body and had been operated on. And if patients met these criteria, including having a high grade of tumor, they were eligible for this study. And this is what we call a Kaplan-Meier curve, which is a curve to demonstrate the two treatment arms. And so what we always want to see with one of these curves, this is what we always wait for in these conference presentations, is that there's something called separation. So the yellow arm is all patients treated with pembrolizumab, and the blue arm is treated with placebo. And this is looking specifically at cancer-free survival, so patients who have no cancer recurrences. And if we look here, you can see that the curves separate, so there's a clear difference between the two arms. And what I try to explain to patients, particularly those who are interested in the trial data, is the goal of our treatments are to put you on the better curve, right? If you receive the treatment, it's less likely at every given time point that your cancer will have recurred. You can still see that there are still recurrences, and I'm going to talk about ways that we're trying to improve upon that with modern therapies. And then this is the overall survival. And there's two things I want to mention. So one is that you do see a separation. It's a little bit later, which makes sense. And the other thing I want to talk about is, looking at 5 years, there's still very good prognosis in patients who met those criteria of having intermediate, high, or high risk kidney cancer. And I think that speaks to how good our treatments are when cancer does relapse. So most patients, by far and large, most patients on this trial were still alive at 5-6 years' time. And I think that is a tremendous improvement in what outcomes have been previously. This is a very busy slide, and I'm not going to go over it in full detail, but what I wanted to highlight, these are all the different trials looking at different immunotherapies in kidney cancer. So this isn't, just because this was the first one we tried. We had used different immunotherapies in slightly different ways or similar ways to what the pembrolizumab study did. So drugs like nivolumab, which you may be familiar with or heard about in the metastatic setting, had been tested. Another drug called atezolizumab was also tested, as was nivolumab with ipilimumab, which are treatments we use. But despite those other trials, the only one we have a significant signal for or improvement on cancer-free survival and overall survival is currently the pembrolizumab trial, the Keynote 564. So to summarize, adjuvant pembrolizumab, it was the first drug to show a consistent benefit in disease-free survival and overall survival. I also mentioned here that sunitinib, which is one of our oral pill form of therapies, is something called a VEGF TKI, which blocks growth factors for cancer, was tested in large trials, but the signals or the outcomes were inconsistent, and so generally not used. There were important side effects for pembrolizumab, and these side effects can certainly impact patients' quality of life. I usually quote, there's about a 10% chance of having a permanent or life-changing toxicity. And what I mean by life-changing is often it requires constant or long-term replacement of something like a hormone that gets destroyed by immunotherapy. And there was significant differences. So if we look at the placebo group, they had a 10% chance of having side effects, probably due to, for example, their surgery, but a 20% increase, or sorry, a 10% increase to 20% in the pembrolizumab group. So these aren't completely benign treatments. And I think it's really important when you have a surgery and you're meeting with a medical oncologist, that is a shared decision. So while it's recommended, it still has to be right for the patient. For lower risk tumors, it may be appropriate to forego the risk of having these treatments. And that is an individualized approach. So I don't think this is a one size fits all, but it's certainly available to patients who are motivated, who have no contraindications or reason not to get immunotherapy, and if it's felt that their risk is high enough to warrant the treatment. one of the questions that I get asked is, why did this immunotherapy beat the other immunotherapies? And the short answer is we don't know. So clinical trials can't really be compared across trials. They're different patient populations and different protocols. We can make hypotheses as to why one drug might work more than the other. Sometimes we think it's because this drug might be particularly active in kidney cancer. The nivolumab trial used a different protocol. They gave drugs before the surgery and after. Maybe that for some reason led to less effective drugs, but we don't know. This is one of the trials that was presented at ASCO GU, which is one of the largest kidney cancer conferences that took place in San Francisco just last month. And this looked at adjuvant pembrolizumab combined with a pill called belzutifan, and that was compared to pembrolizumab alone. So now we're trying to push the envelope further. Can we actually improve upon what we just have shown with pembrolizumab compared to a placebo? Can we do better if we add another drug in? So belzutifan is part of this novel class of drugs called a HIF-2 alpha inhibitor. I apologize for my analogy. This is what I give to like fellows and trainees who work with me. But essentially, sometimes cancer can be really clever. And if you think of it like it tries to induce an alarm or emergency setting in your body. And what that tries to do is increase some growth factors and create a perfect environment for cancer to grow. And if you think of that and you use my poor analogy of an emergency alarm going off in a building, belzutifan tries to shut that alarm off. And it tries to restore kind of quote unquote normal functioning to reduce the amount of growth factors or things to grow in the body. And specifically, this relates to oxygen. So this was the study design for the trial that used belzutifan. So you can see patients either received pembrolizumab and a placebo pill, or pembrolizumab and belzutifan. And this was similar to what the trial I just discussed. It was given for 1 year of treatment in total. It also used the same risk stratification. So the same patient population was included as the trial we just went over. So you had to have that definition of intermediate high or high risk of recurrence. And so far, we have a significant improvement in disease-free survival. So again, it's delaying the time for cancer recurrences, and that could be attributed to patients not having any cancer recurrences. So at the 30-month mark or 2.5-year mark, there is a 75% rate of being cancer-free compared to 69%, or about a 6% difference at 2.5 years. So far, the overall survival data is immature. And what I mean by that is there hasn't been enough events, meaning patients are still alive, which is wonderful. And it means we cannot yet compare the two arms because we don't have enough information on whether or not there's expected to be a significantly improved survival benefit. So we're still awaiting for this. The one thing I wanted to talk about is the summary of the safety results or side effect profile. So if you're adding another drug in, it makes sense that you might be expected to see more side effects or more toxicity from these treatments. And there certainly was on this trial. So I've highlighted here a grade 3 side effect is typically when we consider it to be more serious. It sometimes requires admission to hospital or intense outpatient intervention. So 52% or half the patients on the belzutifan with pembrolizumab arm experienced a fairly high grade side effect. And that's compared to only 30% in the pembrolizumab arm. And so despite them not leading to significantly more death, which is a very important thing to consider, given that we're talking about curative intent treatments, that is still something that physicians and medical oncologists are going to want to be able to counsel their patients about. That increased benefit does come at the cost of slightly increased toxicity. And so what are those? They're mainly anemia, so that's a low hemoglobin count. We often think of that as low blood. It does not mean low iron. And this is a direct effect of the drug. When you stop the drug, typically anemia gets better. One thing I should mention is that grade 3 is typically when it reaches a certain threshold or when you need to get a blood transfusion. And so the dark green bar here is those who required likely a transfusion for their anemia. So it's not quite as high as the 84%. It's only about 15 to 20% of patients with severe anemia. And fortunately is one of those side effects that when you stop the drug, the anemia or blood counts typically improve, and you might be able to reduce the dose and re-challenge or give the drug again. So to conclude, we now have an improvement on the current standard of care in terms of preventing cancer recurrence. We're still waiting to see if that impacts survival. And it was felt that the safety profile was manageable. It led to a low rate of discontinuation, so patients were able to continue on despite having some of these side effects. And it's the first trial that has beat immunotherapy in preventing cancer recurrences, which I think is really, really wonderful. And it holds promise for the future and other trials exploring how to improve cancer recurrences after surgery. So one of the questions I frequently get asked is, well, when can I get this drug? And so unfortunately, we still need to wait for the recommendation to be passed down by the groups that look at drug access. So this will be considered for reimbursement. The recommendation might be that we have to wait to make sure that this actually improves survival data. That's not always the case when we're talking about curative intent. So I'm optimistic that Canada might be able to see this drug be covered by different provinces or via a special access program in the fairly near future. I do want to highlight again that the increased toxicity does need to be considered. And if you think about the financial toxicity to the overall system, it is significant. So it's about $230,000 more when you're adding in an extra drug compared to pembrolizumab alone, based on the estimates that I could find. But of course, we all want the best outcomes for our patients. And so there are health economics specialists that will do the appropriate calculations to see if this meets that threshold of being publicly reimbursed. I'm now going to pivot to talk about how do we best treat patients who have stage 4 or advanced kidney cancer. And the one thing I want to emphasize before getting into that is I think of kidney cancer as one of those cancers like snowflakes. No two kidney cancers are identical. And so what I talk about tends to be fairly generalizations. And I want to make sure that if I'm talking about treatments or strategies that are different to what you've heard in loved ones or yourself, that there could be very good reasons as to why that is, because it truly is one of those cancers where no two cases are the same. And I think that's why it can be so interesting and why there's been so much development in this field. So I just wanted to kind of give us historical perspective on where we are. And what I think is amazing is if we take us back 1 decade, so to 2015, you can see just how much we've improved our management of kidney cancer patients who have incurable disease. And I use that word incurable with a little bit of a caveat, because there are a percentage of patients, it's not high as we would like, but that can achieve long-term remission even if they have metastatic disease with modern-day therapies. But we typically think of phase 4 as having palliative intent therapies, meaning we're trying to prolong survival and make people live as well as we can. But I think it's important to recognize, that we've really exploded in our drug access in the past 10 years. So up until about 2010, probably slightly earlier than that, we used to talk about kidney cancer as being a surgically managed disease. We didn't have effective treatments. And then since then, we've had this explosion. And I think kidney cancer is one of the poster cancers for the fact that we can make such meaningful improvements with modern therapies. And so this is the 2016 onwards is what I'll talk most about. These are what really have changed standards of care and modern day algorithms for oncologists. And I will, of course, mention at the end, 2024, the only new addition to this historical context is belzutifan. I shouldn't say only, but one of the major ones in terms of new drug development. So we entered in what I'm calling the immunotherapy combination era, pardon me. And so we started to combine different types of immunotherapy with either another immunotherapies or pills that are VEGF TKIs, which I said are medications to try to stop growth signaling in cancer cells. And so we started with nivolumab, ipilimumab, which are 2 immunotherapies. Shortly thereafter, we had our first immunotherapy and TKI combination, which is pembrolizumab. Then we had lenvatinib and pembrolizumab, and then very shortly after, we had nivolumab cabozantinib. And so we kind of had this, explosion of different options. And I will say, I think Canada has been very fortunate to be ahead of the game in having multiple options approved across the different provinces. And you can see here that the comparator arm in each of these trials was a drug called sunitinib, which is still certainly used and is a very good drug for some patients. But that was standard of care prior to this development. I'm not going to go too much into detail about all these trials, but I will kind of compare. So again, I've mentioned earlier that we should be careful when we're comparing trials, especially when we look at things like median survival or expected survival in those trials. And that's because there's a lot of issues when we compare trials. They might have been, doing scans at different points, for example. They may have slightly different patient populations. And so using crude numbers is not very helpful. What we sometimes do, and again, it's a bit haphazard, is we want to look at something called the hazard ratio. And the hazard ratio is really just a statistical representation of the likelihood of any event happening on one treatment compared to the other. So in this situation, we are comparing the likelihood of survival on ipilimumab compared to sunitinib. And this was at 99 months. So this has really mature or long-term follow-up data. And so, we have lots of data on these patients. And you can see that there's a 28% reduction in the likelihood of death, unfortunately. But that's a reduction, which is good. So a number less than 1 tends to mean that the comparator or new treatment is better than the old standard of care. That's a pretty rough analysis, and if there is any statisticians in the audience, are probably rolling their eyes, but that's the best I can do. And so we can see here that all of these treatments, the hazard ratio is less than 1, meaning that the likelihood of survival is better than what it was on sunitinib, which is excellent. They are fairly similar. So I want to emphasize the fact that because this is 0.84, that does not mean that this combination is inferior to any of the others. You can also see that the follow-up is longer, which may have influenced that. And there are changes over time as we get more data. So how do oncologists choose the right treatment for the patient in front of us? Sometimes this is purely based on availability. So as Christine mentioned, before coming back to Canada, I was practicing in England, and there was far less options. So it had just started, and it was probably 2 or 3 years behind Canada. So our choices were really limited to what drugs we had access to. We often take into account if we have a perfect scenario like we do in Canada, where we have multiple options, we often take into account the patient who's in front of us. What are their goals? What are their preferences? Some of these different pills have different side effects or side effect profiles, and what ones might be more impactful for one patient than the next. There is something called a risk category. You won't hear me talk too much about IMDC classification, and that's intentional. So people often get labeled as having this good risk disease or intermediate risk disease or poor risk disease at diagnosis, and that might be terms that oncologists use with patients. And I think that is certainly it's a Canadian discovery. I think it's a wonderful risk stratifier to be able to have that tool to discuss with patients, but I think there are drawbacks when we're talking about immunotherapy. But some of the drug approvals are contingent on being in a certain risk category. And there are troubles with that I won't get into right now unless there's particular interest to, but that was designed from the clinical trials. Not necessarily because it's right, but that's unfortunately what has trickled into our drug approvals. There are also times where oncologists might say, well, we're really worried that if we don't get very quick and rapid control of the disease, we might be in a very difficult situation. So this idea of choosing the treatment that has higher likelihood of response may be relevant. And of course, prescriber comfort. And sometimes institutions have preferences on what drugs are used. So that was really the combination era. And I think that's really dominated a lot of the kidney cancer talks and events in the past 10 years for a very good reason. There was 4 different combinations that have improved. And then this question was asked, well, if 2 is good, so if ipilimumab and nivolumab is good and nivolumab and cabozantinib is good, what if we combined all 3 and came up with cabozantinib and nivolumab and ipilimumab? And I'm only presenting this as kind of somewhat of a cautionary tale in which intuitive thinking is sometimes not always the right answer in oncology. And so what we saw here is that patients who received all 3, ipi, nivo, and cabozantinib, did no better in terms of their survival compared to ipilimumab, nivolumab, and a placebo pill. It was also noted that the triplet was much more toxic, and I participated in this trial, and there were difficulties in managing, for one, patients if you didn't know if they were on cabozantinib or placebo, and it was certainly a difficult trial when it came to side effect management. And so as it currently stands, and based on the current evidence that I have today, there's no clear role for combining all three or triplet therapy. And so more drugs is not always better for everyone. They're doing lots of exploratory analysis on these trials to see if they can identify who it might benefit from. And so we'll stay tuned for that. So those are really the first line options that we have. And so the question then is as well, if they don't work, if a patient has cancer progression, their cancer is no longer being controlled on their first line of defense, what else do we have? One of the questions that I get probably most often when patients have had good responses on immunotherapy initially is, again, it would make sense to ask, can't we just try a different immunotherapy, particularly if it was well tolerated? We know that immunotherapy drugs tend to be very well tolerated. Again, it goes back to the comment of always being that risk of having serious side effects, but probably 70% of patients have very little side effects or manageable side effects that don't require treatment breaks. And so it is tempting to want to be able to recycle or give another immunotherapy if the first one works. And so we tested this in something called the CONTACT-3 trial, which looked at giving atezolizumab and cabozantinib compared to just cabozantinib. So now we're testing an immunotherapy with a pill versus just a pill in patients who had progression after immunotherapy. This was a pretty heterogeneous trial. And what I mean by that is it included lots of different patients because the criteria was just that they had to have progressed on immunotherapy. And so you're getting patients who have had different lines or number of treatments in the past and different drugs in the past. And that's always difficult. It creates quite a dynamic or kind of, this heterogeneous group where making conclusions may be more difficult than the patient who's in front of you. Unfortunately, this trial, similar to the last one I talked about, showed no improvement. And so the thought is that maybe, immunotherapy, you have one good shot at immunotherapy to see if you'll get benefit, and recycling or rechallenging hasn't proven yet to be effective. There are other trials that are actively exploring this. And so I think we're eagerly awaiting those results. There are some thoughts that maybe atezolizumab may not have been the right immunotherapy to be tested in this setting, given the challenges it's had in other disease settings. So maybe other more effective drugs might hold more promise, but we'll have to stay tuned. So as it currently stands, and again, of course, there are exceptions to this rule. Typically, there's one line of immunotherapy used, and most often that's given in the front line or first setting. I'm now going to talk about a rather new trial, something called LENCAVO, which looked at a combination of lenvatinib and a drug called everolimus, which is actually a fairly old drug. It's been around for quite a while. And this compared to cabozantinib. And the reason we're starting to do these trials is when we create a brand new treatment paradigm, we've completely shifted from what we used to be doing. And now we have these brand new treatments we can use in the front line or first line setting. We now don't know what the best treatments are to use after that they fail, unless we do trials. And so this looked at the combination of lenvatinib and everolimus, which is actually a combination used in later line settings in the UK, less so in Canada, although I think there are some oncologists who do prescribe this. And it compared it to cabozantinib, which is typically considered to be quite a good later line drug. I want to highlight that this is a small trial, only 86 patients, and that would be considered very small, so difficult to make meaningful conclusions for a wider population. It did show that progression-free survival, again, that's a term we use for how long the cancer stays controlled for before we see growth. And I'll talk about some nuances to something that we call progression-free survival, but it was longer by just over 5 months for patients who got lenvatinib and everolimus compared to cabozantinib. There's still no statistically significant benefit on survival. So we do not yet know if this means patients will live longer. And it should be noted that about 1 in 5 patients had to discontinue the treatment of lenvatinib and everolimus because of toxicity, compared to only 1 in 10 patients with cabozantinib. And that would be a relatively high discontinuation rate for a treatment that has palliative intent. or trying to prolong survival and improve quality of life, if 1 in 5 patients have to stop the drug because of toxicity, that often suggests that there is interference with quality of life. And so this is that curve. And you can see so far in the survival curve, they're hugging, meaning they're not clearly separated yet. So when we think about this combination, I would say I think we have to be careful to make big statements on whether or not these drugs are truly, the combination is better than cabozantinib. I would say because it was a small trial, this might be considered a signal of benefit. It's hypothesis generating. It might need further exploration in larger trials. And I don't think we can make definite conclusions about that combination being better than cabozantinib. Again, progression-free survival is this endpoint or outcome we measure in clinical trials. And I think it's really important to take into consideration how important that is. So, of course, if we say to patients, we can control your cancer for longer, that inherently feels like a good thing. But if we're not improving survival, some patients would say, well, look, I don't want a more toxic treatment if we're just preventing growth on a CT scan, which is really how we measure progression-free survival in most instances. And so there's cutoffs that we use so that all clinical trial sites are using the same language and making the same decisions on whether or not we should continue or stop a treatment. That doesn't mean it's always clinically relevant. So sometimes in a clinical trial, we're forced to stop a treatment because a tumor has grown by, say, for example, 25%, even if the patient's feeling well. And so I think that we always have to be careful when we make drug recommendations or approval recommendations based on just progression-free survival. We've actually studied this. We've asked patients in a very robust way of how important this endpoint is to you. And this is not done specifically in kidney cancer, but in a number of different cancers. And what we find is patients really, once they're explained to what progression-free survival is, they may not value it as much as things like quality of life and toxicity. Survival is certainly one that is typically the highest ranked for good reason. So how am I using this in my practice? So of course, this isn't something that has yet been funded as a standard of care approach. I would prefer a larger study, and I would certainly want overall survival data, even in the small population, to be convinced that it's worth the increased toxicity. I'm going to go back to belzutifan, which I like to think of as a new kid on the block, because this is making its way up the chain. So often in cancer care discovery, we start in situations where patients may not have other options for treatment. And that's where we test a benefit. And then if that's successful, often we work its way up. You can see that's happened quite quickly for belzutifan because it's already being tested in the curative setting after surgery. And that usually is a reflection of being convinced that there's activity. This is a drug with good benefit in this type of cancer. And so this was a trial comparing belzutifan versus a drug I just mentioned called everolimus for advanced kidney cancer. And again, we talked about the mechanism. Again, this is trying to shut off that alarm system so the body doesn't go in that stress response, which could fuel cancer growth. There is a condition called von Hippel-Lindau, and this is a genetic condition where patients are more prone to developing renal cell carcinomas, and they often have multiple tumors, which makes surgery very difficult. And so belzutifan was first a big success story in controlling multiple tumors in patients with this condition. And it prevented the need for multiple surgeries and preserved renal function. The question was then asked, well, if it works in that specific condition where kidney cancer is common, might it work in patients with metastatic disease? So they did this trial called LIGHTSPARK-005. And it showed that there was a progression-free survival. There's that term again of controlling the cancer, but no overall survival benefit. And everolimus has historically been considered to be a fairly weak standard of care, meaning it doesn't work in all patients. However, I think what's really important is that the quality of life data and safety profile, so the side effects were better in belzutifan than everolimus. So this quickly became, and there was met with enthusiasm of maybe being another treatment we can use that controls cancer, preserves quality of life after patients have progressed on immunotherapy and other drugs. Then the question was asked, can we use it earlier again? And so this was a different LIGHTSPARK study looking at belzutifan plus a VEGF TKI, one of the other pills that stop growth factors. And again, it was compared to cabozantinib. And this was again just reported at ASCO GU, so just last month. And so this is the study design. So they had no more, so they had two or fewer, prior treatments, and they had to have had disease progression on an immunotherapy, and that was really it. They could have had prior VEGF TKIs. It was not a requirement. And we're seeing a similar story. So we see an improvement in the progression-free survival. So the cancer was controlled for longer when we used belzutifan with lenvatinib than when compared to cabozantinib. We're still waiting to see if this turns out to be statistically significant. So this has not yet met that threshold of saying this is definitely of benefit in terms of survival. If we look at the side effects, they're fairly consistent. We see things like anemia, again, low hemoglobin or low blood counts being common in the belzutifan group, but I would say these look fairly consistent. So I think this is holds promise to be an exciting new treatment, and we'll wait the survival data to see if this can become a standard of care option for patients. I'm finally going to talk about how we can improve our current therapies in terms of drug delivery. So something that's making its way, I would say, relatively quickly into practice is this idea of being able to deliver immunotherapies via subcutaneous route, or compared to what we typically do, which is intravenous. So intravenous drug delivery is when an IV catheter is placed somewhere in the body, and then we infuse immunotherapy as a bag of fluids into it. But we can give immunotherapy through small needles that go underneath the skin, and the drug is delivered directly there, similar to how insulin is given in diabetic patients. And there's clear benefits to being able to do it under the skin compared to intravenously. It's much faster. It doesn't require an IV, which can be painful or difficult. And it's designed to work the same way, despite a different way of giving the drug. So the goal is same cancer control, a simpler delivery. And so when they started developing subcutaneous routes, they did all these trials in different types of cancer. And fortunately, it has been done in kidney cancer or renal cell carcinoma. So they compared nivolumab, subcutaneous versus IV. And these trials are designed to show that the subcutaneous route is not worse than the intravenous route. And it met that goal. So the response rates were similar. So if you look, it looks like, wow, it's even better. We're not able to make that comparison because, again, the study wasn't designed to show one is better than the other. It was shown to say that one is not worse. And so that met this threshold. And that's true for both the response rate, so the likelihood of having cancer control, the progression-free survival I keep talking about, the overall survival, as well as safety and tolerability. Time savings are huge, right? For patients, it's only about a 5-minute procedure with monitoring compared to a 60-minute infusion and monitoring plus getting an IV. So there's benefits for patients. And of course, for that means more patients will be able to be treated per week in a cancer center more efficiently. So I do think this is likely to become standard practice where available. It's very exciting for drug delivery. And if this is proposed to anyone or their loved one, I encourage them to talk with their oncologist about this as an option. I think it'll likely become real time in 2026, we're hoping, and not just with nivolumab, likely other immunotherapies as well. Those are the key things I wanted to highlight. I'm happy to take questions and open this up for discussion. I think we've had a lot of exciting advancements in kidney cancer. We're certainly hoping we see that trend continue. And again, it's been a real pleasure being here this evening with you all.
Thank you so much, Dr. Young. This has really been an informative, detailed presentation, and I'm very grateful. And I actually have some questions, and I see there's other questions that are coming forward. I'm going to apologize for my lighting. I was in one of those areas that was severely affected by the ice, so I'm just keeping my fingers crossed how our generator keeps working. I had a question in the Q&A, and I'm not sure if you noticed, by a patient. When adjuvant therapy was offered, she was told that there was only one study that showed a benefit, many studies that do not. And I know you touched on this, but could you just reaffirm, has this changed?
Yeah, I would say it hasn't changed with the exception of now having another study that shows the same drug pembrolizumab in combination with belzutifan has a benefit.
Mm-hmm.
But it is true, and I think that's a really important part of the conversation when we're meeting with patients to discuss the option of having immunotherapy.
Mm-hmm.
Pembrolizumab was one of the trials that read out last, meaning we got the results later than the other trials, and so there was a few years of having one negative trial, meaning a trial that didn't show benefit, after the other with immunotherapy. So when
Right.
we had this trial that showed a positive, a significant benefit, there was some skepticism. And I
Mm-hmm.
think that's important skepticism because it questions, why are we seeing that difference? And some people have interpreted that as, well, look, I don't think it's a fluke. We enroll thousands of patients into these trials. That really reduces the likelihood. The chance of having a fluke result from one trial is
Mm-hmm.
almost statistically impossible. So I
Right.
think the benefit is real. But I think it should be interpreted in the context of, well, other immunotherapies haven't shown that same benefit. And so that's why pembrolizumab is currently the only accepted standard of care option for the immunotherapies, but absolutely still true.
Right. Good. Thank you. I'm going to kind of start at the beginning and come to the end, and I'm going to invite our attendees, and I see that we have quite a few. If you have a question, please type it in the chat or the Q&A. You'll see it at the bottom of your screen, and that way we can ask the question of Dr. Young. So please try it not patient specific. So if you have a specific question regarding your treatment, unfortunately, we don't do it in a public forum. You could send us the question privately to info@kidneycancercanada.ca, and we will try to get you the answer. But if you have a general question, please type it in and we'll ask it. I was so pleased to see you mentioned the Zircon trial, because this is something I've been working with a company. It's called Telix, and unfortunately, it's not in Canada yet, but we're working very hard to get it here. Are the trials available in Canada or still only in the US?
It's a great question. I wish I had the answer. So the Zircon trial has closed to recruitment. So that's
Okay.
where we're starting to get the results.
Okay.
But there might be other trials ongoing. We do not have the girentuximab
Right.
PET scan available in Newfoundland, and I don't think it's being widely done
Not
anywhere
quite
in the
yet.
country yet.
Yeah.
I mean, we have similar. So in prostate cancer, we have something called the PSMA PET scan, and that
Yes.
took probably the better part of a decade from the first real use to become widespreadly used. And I think we're probably going to see similar, delays in getting the access. These scans are costly and time consuming.
Yes.
And so unfortunately, with any imaging modality, it's not as quick as our treatments are in getting, to real time for the patient.
Yeah.
But I'm really optimistic because one of the challenges, of course, lots of times patients in the workup of their kidney cancer, there's a lot of delays and, the possibility that this could be benign, this could be malignant, and that's
Exactly.
terrifying. And so having a scan that can give you an answer more quickly,
Mm-hmm.
I think is of real value.
Mm-hmm. I agree. And I actually, you mentioned ASCO GU. I attended a patient ad board, and they were talking about delivery of treatment using that same methodology,
Yeah.
which is very, very targeted. Like it
Yes.
delivers it right to the tumor.
Yeah.
And this is without systemic therapy, so to speak. So these are
Exactly.
exciting things that are coming forward. As you say, it just takes a little time.
Yeah.
The other thing that really interested me was you mentioned SBRT, and it was a trial, and you did a large size up to 10 centimeters,
Yeah.
which is usually not customary. Is there something that would prevent an older patient who maybe had comorbidities, and this would be the ideal situation? Is that available in Canada for those patients?
Yes, yeah. So, and I can say that confidently because it's something that our site here in Newfoundland started about 2 months ago.
Okay.
And we've also been sending patients out of province to larger centers who've had a lot more experience, particularly in those challenging cases. So either bigger tumors or
Yeah.
maybe something anatomically that makes it challenging. So I would say it is certainly becoming an option for patients across Canada.
Okay.
And you're right. So up to 10 centimeters, when I read that, I was thinking, wow, that's a gutsy trial. Good for
It
them,
is.
right? They
Yeah.
allowed these patients who were in that gray zone of likely needed a treatment.
Yeah.
Our definition of what we consider to be a small renal mass is typically less than 4 centimeters.
Yes.
Often those patients, provided, they're not eligible for surgery get monitored. But now we have this as a really attractive option, as something
Yeah.
that can be done, and including in pretty large tumors. And so I can say that our radiation oncologists in Newfoundland have used that cutoff and have been
Mm-hmm.
applying that. And so they've been giving SBRT to higher tumors than what we typically had been considering before that trial.
That's great news. Especially, I often get requests, what can they do? Because they're not eligible for systemic therapy for our older, our more senior patients. And so this might be an option, depending on, but it doesn't hurt to ask
Yeah,
and see if you might be a candidate.
yeah.
I have a question from the audience that asks, does RCC always recur?
Great question. And I'm happy to clarify so that no. I would say the majority of cases of renal cell carcinoma after surgery do not recur. And that is a really important point. So I'm glad I'm able to clarify. So there are, the trials I'm talking about to prevent disease recurrence, they tend to be in the high risk disease, the bad
Mhm.
actors, if you will.
Right.
There's a large proportion of kidney cancers that are incidentally found or slower growing, and those are unlikely to recur. And that is one of the discussion points I have with patients when I get referred. So as a medical oncologist,
Mhm.
especially after surgery, I'm typically seeing the higher risk patients. And I don't see the lower risk patients because they're not referred for the discussion, because the likelihood of their cancer recurring is very low. And
Right.
so the prognosis for kidney cancer patients after surgery, in the majority of cases, is very good, excellent even. What the treatments I'm talking about are trying to improve upon, particularly for the ones that have higher risk. Uh,
Mhm.
and if there's questions about, I would encourage anyone who's had surgery for their kidney cancer to ask the doctor who did the surgery, what is my perceived risk of this cancer coming back in 2 years and 5 years? Because we do have ways to help predict that. They're percentages. They're not specific to the person in front of them, but it's trying to give you a rough idea of whether or not this was a bad actor or if this is
Mhm.
something that we caught and is very unlikely to recur.
Excellent, thank you. And you just actually brought up two notes that I was going to speak to. You spoke about, you did give quite a good talk on the adjuvant therapy, and that is something that we're kind of lacking information on because it is relatively new in the scheme of things.
Yeah.
I just wanted to remind our attendees and our audience that we'll see it on our website later. We do have the updated decision aid on adjuvant therapy on our website. So if you're looking at that information, please check it out. And we would also email you a print copy if that's what you'd like, or mail you a print copy. Another thing that you said, and I am now going to take advantage going forward, I have always said every kidney cancer is unique. No two patients seem to ever be quite the same. And in the same token, that their treatment, what works for one, is horrible for another. But I love the word snowflakes. So I'm going to steal that from you and adopt that going forward. Um, you brought up a lot of different um, a lot of different information in regard to treatments, and you talk about rechallenging a treatment if it worked. Is that cost covered if they rechallenge?
Good question. So currently, no, and that's because we don't have evidence to do so. Now, I'll be careful in saying that there are some times where you stop a treatment for, say, a side effect. You might
Uh-huh.
be off that treatment for even a year, and then you re-challenge, but your cancer hadn't worsened on that treatment.
Uh-huh.
But currently, most reimbursement models that I'm familiar with across the country do not reimburse for another type of immunotherapy if you had progression of the cancer on one immunotherapy.
Okay.
And that goes to the contact trial, which showed that there was no clear benefit in doing so. So
Mhm.
until there's a trial that shows there might be benefit, I suspect reimbursement algorithms will not provide that.
Okay. I
Yeah.
appreciate that. Thank you. Um, I also appreciated the fact that you recognize patients have a different perspective on what outcomes are important to them. And, some are just quality of life. Some are, they're looking for that cure and they want to be aggressive. And we find that stable is an excellent word for a lot of our patients. So just maintaining the disease so that there's no growth or, like recurrence in other organs. So that's really important, I think, for our oncologists today to take that into perspective. We do have a survey on our website that kind of gives you some questions that, this is a conversation you can have with your oncologist. So I congratulate you on being so forward thinking about what the patient deems the best for them. So thank you very much for that.
Oh, thank you. I mean, it's one of those things that I think we get a little bit of a bad reputation at times because, we have these conferences and we see, oh, this drug can shrink tumors by 30%, and we're all standing up and clapping because we're thrilled because we want the best for our patients.
Mm-hmm.
But if that shrinkage comes at the cost of a patient having no quality of life, we haven't done our job in that trial. And I think that's
Right.
really important. And for every patient, their goals might be slightly different. So one patient might care, they might not care about number of years as number as good years. And I think finding that balance and understanding what the patient wants from the treatment is much more important than what the doctor wishes to accomplish from the treatments.
Thank you. I have two quick other things.
Of course.
If you can stay. We have a lot of our patients, because the drugs are working so well, they're thriving well beyond third and fourth line. Is there any information that you can share with those patients? I have a patient that's on sixth line and they're thriving. They're doing well. I mean, they do have complications with side effects, but for the most part, they're thriving. Do you have any information for them or encouragement for them that might help?
Yeah, it's a great question, Christine. As a clinical trialist, I should always mention that I think a clinical trial is always worthwhile exploring. So
Okay.
if you're meeting with your oncologist and they say, I'm not sure what to give next because 6 lines of treatment, you've seen most of the ones that we have. Ask about clinical trials, ask about referral to clinical trial centers if you live, if that's not your primary site for your cancer care. I'm a big believer in clinical trials. I spent 2 years doing kidney cancer trials, and I can tell you, we had patients that, were on line 7 and 8 of treatment, and they got one on a clinical trial that worked. And that's always what we hope for, and that's why we're running these. So ask about clinical trials, and I think important to know there are still things coming, right? And so the pipeline changes. Every time we go to one of these annual meetings, and we have them multiple times per year now, we walk away with an improvement in kidney cancer. And I think that's really important to know as well.
Thank you. Thank you. So always ask about a clinical trial, no matter where you are.
Absolutely.
And last thing, I just wanted to bring up the sub-Q. This is really coming, and we are excited because this is an excellent option for our patients in remote and rural areas.
Absolutely.
So there's always the question a little bit is it going to act the same? Is it safe? And the information is coming out that it is. Can you just expand on that just a little bit?
Absolutely. So, they have that's relatively small trial in kidney cancer, which again was a non-inferiority. So not trying to show that subcutaneous is better or worse than IV, just it's no different. And that's what it showed. So the efficacy, the best data we have suggests that there's no deterioration or worsening of efficacy. And that's consistent. I don't like to expand kidney cancer and say, okay, well, what happened in lung or what happened in breast? But what we're seeing is a very consistent signal amongst all different cancers that the route of delivery is equal. And there are very fancy pharmacokinetics, meaning they measure drug in the body and how well it's working. And PK studies are called. And those have been fairly consistent that subcutaneous is not inferior to intravenous. And so some of the modern trials in different disease sites are starting to take advantage of that. And they're starting with subcutaneous route. So I agree with you. It is coming. And working in Newfoundland, and half my patients are outside of the city, and I'm seeing them remotely. I think it's fantastic. And I mean, this will also really improve wait times to get started on chemotherapy or systemic treatment or immunotherapy, because we'll be able to treat patients more efficiently. So I think it's wonderful. I've been working really closely with our site here to try to get it off the ground as soon as we're able to.
Okay, great. When I attended a conference in Newfoundland, I learned that some of the patients in Labrador, like it's a 3-day trek for them.
Yes.
And my God, can you imagine having to do that on a regular basis? So
I know.
This is a great option.
Absolutely.
And one last question from the audience about chromophobe. And this is always a challenge.
Yes.
Is there anything new? Is there something they should consider?
Yeah, really good question. So thank you, Wendy, for the question. I think it's important for me to go back and say that a lot of the sweeping changes in the algorithm have really come on clear cell renal cell carcinoma, that
Yeah.
80% one. And it's been more challenging to make these big changes in how we treat as standard of care options for the variant histologies, which includes chromophobe RCC. Um, I'll be careful in saying that in Newfoundland, anyways, and what I think is similar across the country, sometimes we're not limited into what we might be able to access, as long as it's not requirement for, say, an insurance company or what have you. And we often extrapolate, but that there's some error in doing so. You know, when we've looked at chromophobes specifically, they
Mhm,
tend to respond probably less well to immunotherapy. They
mhm,
might also respond less well to VEGF TKIs. That's not to say you cannot get a response with either treatment in a chromophobe RCC. I have
mhm,
certainly seen patients have fantastic response on both types of treatments in chromophobe RCC. Everolimus might have a slightly better evidence. It seems
mhm,
to be more sensitive to the mTOR inhibition, which is that class of drug.
mhm,
And so often that would be one that I would consider if I'm not achieving a desired result.
mhm.
And again, I would say whenever there's that question, speak to your oncologist about whether or not it's pure chromophobe RCC. Are there any clear cell features? To
Mhm.
get an idea of, you know, what likelihood is that you can extrapolate some of these other larger studies to that subgroup particularly. But Wendy's brought up a really important point, is that we need better studies. We
Yes.
need continued efforts so that our variant histology renal cell carcinomas are not forgotten. So
Mm.
in the momentum that we have moving forward, it takes longer to recruit to these trials, but still very worthwhile doing so. We know how to best treat the patients with these different histologies.
Okay. Thank you. Very well said. And it's surprising, but just with our patient relations, we found that we have quite a large population of chromophobe.
Yeah,
So we really, we kind of bang our head against the wall knowing how we can help these patients, but maybe, we need to get a bit of an impetus, with some patient stories or something, and maybe it would help
yeah.
push things along a little bit. So we'll certainly consider that going forward. I can't thank you enough. This has been so informative and such patient-friendly language. I really, really appreciate it. And I know our audience does as well by the hearts going on the screen. Um, Thank you again. And just a reminder, this wonderful talk will be included on our website in the near future as soon as editing is done. And I hope that we can entice you once again, Dr. Young, when new things
Anytime.
develop.
Thank you
Okay.
so much, Christine. Thank
Thank
you,
you.
everyone. Have a
Take
wonderful evening.
care. Bye night.